Here to talk with us is Dr. Caitlin Thompson. She's a psychologist who leads the Suicide Prevention Policy Program at the VA. And the president and founder of Give an Hour, Dr. Barbara Van Dahlen. Give an Hour provides free mental health treatment to service members, veterans, and their families. And Atlantic senior editor Ross Andersen is here with us to lead the conversation. Ross.
Okay. I want to ask a question for both of you, really. And I think there's this sort of common narrative that people have about veterans, where Vietnam veterans experience this like tremendous sense of alienation relative to World War II vets. And I suspect that's an oversimplified narrative, so I want to ask you about that. But I also want to ask you what's been distinctive about the experience of Iraq and Afghanistan veterans returning home.
Thank you. First, it's such a pleasure to be here and to be with this extraordinary audience. And thanks, Ross, and lovely to be here with you, Dr. Van Dahlen. So the experience that we understand for Vietnam veterans when they returned home is that sense of not coming home to the parades and not coming home, not also going into service in a very alone way. They were not going in on force as they were in World War II. That's a very similar type of experience, I think, that our Iraq and Afghanistan veterans have had as well, with a kind of urban warfare and not knowing what was going to happen next. So I think the resulting coming home has been very different. There's certainly been a lot of important media attention on our younger veterans, which is fantastic. That, of course, our Vietnam veterans did not have, and so I think that's one distinction.
Also, I'd say that one of the things that's very different, that has been very positive for the Iraq, Afghanistan veterans, is that our nation really welcomed them home in a very, very different way. There was a lot of recognition of their service, their sacrifice from the beginning. You know, you couldn't go into an airport without seeing, you know, welcome home, welcome back, at ball games, at events. Now we have come to understand over the last decade that can cut both ways, and maybe we'll talk a little bit about that in terms of the impact on the service member, because sometimes we put them up as heroes, which makes it harder for them to say, I'm struggling, I'm hurting too. Mm-hmm. But they did not deal with the negative reaction that came home during the Vietnam era veterans.
Mm-hmm. Caitlin, I want to ask you about at the VA, how you guys are thinking about the trauma that people experience in wartime versus sort of the other kinds of trauma, just sort of normal trauma that people encounter here, you know, in a car accident and so forth. Like, how does that kind of ripple into their life?
Yeah, it's such an important question. One big reason that trauma in war and trauma in being a service member is so distinctive is that there is always sort of that underlying expectation that a trauma is going to happen. Mm-hmm. So there's this constant hypervigilance when one is serving, which makes it so that sleep is an incredible issue. And one of the things that we know about suicide is that people who have more sleep difficulties have higher rates of suicide. So that has been found to actually be a correlate, and one that I think is very specific to serving. So it's a type of trauma where you're just constantly waiting for something to happen and not knowing when it's going to happen, as opposed to something like a car accident where it really comes out of the blue. I do want to make one point, though, in terms of suicide prevention and thinking about veteran suicide. One thing that we do know is that veterans who have never served, never been overseas, never deployed, have higher rates of suicide than veterans who have deployed. So that's a different change in the narrative that we typically expect, that you deploy, you have a very difficult experience, you come home and you're suicidal. It's making sure that we're looking at all veterans, no matter whether they've deployed or not.
And if I might, it's telling us that this issue is extremely complex.
Yes.
And one of the things that we've come to understand is what people come into the service with, their family history, often a family history of trauma that sets them up for potential different or more intense reactions to additional trauma.
Barbara, are there time frames that you your organization is this vast volunteer network of mental health professionals, and you guys are talking to veterans at like all of these different life stages. Are there particular time frames that you've found where people are especially vulnerable to this really dangerous kind of levels of mental anguish?
Well, I think that that's a complex question for a complex situation. Certainly there are we think about when people are in the heat of battle, literally, they're deployed or they're training or they're coming back, the intensity and the focus on I need to take care of myself, my buddies, my unit, keeps people moving forward. And we all can relate to that. When you're in a crisis mode, you function. And then sometimes when you come back and there's the quiet. So after the parades, we hear from veterans that, their family was ready to welcome them home and everything's done. Now we get back to life as normal, but for veterans, that transition can be very challenging. So that transition phase after the initial, hey, we're back, everything's great. We also know that for older veterans, as they end their careers and they're looking at retirement, whatever they perhaps did not deal with comes back, and that's why we're seeing, people think the 22 a day is our young veterans, and we know that the majority of them are veterans over 50, 55. Yeah. And so that's another period of time. And then the other period that, of course, is more common to trauma in general is people who have experienced multiple traumas in theater and then coming home. I'm thinking now of military sexual trauma is also a huge risk factor. That will put someone at a higher risk for that period of time.
Yeah. I've been hearing a lot about this idea of moral injury, right? Which is unlike a sort of wound that affects your body, it affects your conscience. And it's distinct from trauma, as I understand it. I know that's kind of a relatively new idea. Has that started to kind of trickle out into the actual practical treatment of veterans?
Certainly, yeah. I mean, moral injury is just really coming to the forefront, even though it's something that I think that we really think we understand that Vietnam veterans, especially who come home and talk about the guilt associated with doing things that they were told to do, and then coming back and kind of coping with those, I think is a big piece of it. So at VA, we're certainly learning more about it and trying to better understand it. I worked in the Veterans Crisis Line for 5 years, and we would frequently get phone calls, especially from our older veterans, saying, this happened to me 30, 40 years ago. I've never told anybody about it, and I'm so glad that I can talk with you about this experience over the phone without a face, but being able to have that kind of confession in many ways. But we're certainly learning more and more about moral injury, and I'm very interested in seeing what we can learn.
And groups are stepping up. There was recently a gathering that Volunteers of America put together to bring a bunch of us together to talk about this issue of moral injury and how we're seeing it play out and what we need to do to be sensitive and thoughtful. And again, it's not unique to veterans. It does occur in other populations, in other settings, and it's something that I think it's easy to wrap your brain around how it could happen, the sense of betrayal or loss of focus or purpose, and the impact that has then can really be emotionally extremely traumatic and destructive, and really eat at someone's core sense of self.
Mm-hmm. Barbara, one of the things that's really remarkable about Give an Hour is just the range of issues that you guys address, from marital counseling for veterans, sexual and intimacy issues, substance abuse, grief and mourning, et cetera, et cetera. And I sort of wonder where that kind of holistic approach came from. Mm-hmm. Can you speak a little bit to that?
Sure. So as a clinical psychologist and a child psychologist, my father served in World War II, and so that was really what prompted me to start Give an Hour 11 years ago. And I grew up in a rural community in California. I was trained in a clinical program that had a community emphasis, and the awareness and recognition that one size doesn't fit all, that these issues affect people in a whole range of ways, their relationships, the feelings they have about themselves. It led us very quickly to recognize we had harnessed 7,000 mental health professionals all over the country. They all have different skills and abilities. We wanted to turn those on so that veterans and military families could invite, ask, and receive a variety of different approaches. We do a lot of training. We work closely with our friends at the VA around that to make sure we focus on evidence-based care. But the reality is, even the best evidence-based care does not provide for everyone. So to make sure we ensure that people have access to a range for what they need is really critical. And we're really proud that we've now given 185,000 hours of care. And it's all variety of care for all variety of issues.
Caitlin, I know you guys are doing some really innovative things with predictive modeling at the VA. Can you tell us a little bit about that? Particularly, I'm wondering, and these models, I guess, sort of like flag people who are especially at risk for suicide. And what are the warning signs that would show up in a data set versus like a sort of one-to-one conversation with this person?
Yeah, it's such an interesting and new idea, is kind of using that bigger data to call factors that you might not even consider as being part of, within this model, predictive of somebody having higher rates of suicide. But we've been able to really distinguish a very, very small percentage of people who may not have even sought mental health care, who then we can really tailor our interventions to. So we're in a pilot stage right now for our interventions, so that the data sets are running through our electronic medical records. It's one of the really beautiful pieces about VA care is our medical records, very integrated, so that we can pull hundreds of factors, weigh them, and find out who might be at the highest risk of suicide, continue to hone that model, and then develop interventions around that. It certainly doesn't take away from that essential clinical experience that you have in talking with somebody, but it absolutely can set the stage for that experience to then happen later on.
I want to open it up briefly for any questions from the audience.
Before we do that,
Sure.
there was one thing we talked about that I really wanted to get out here, because it is such an incredibly important part of this conversation, and it has to do with the work that we started doing a year ago because of the recognition that we can't expect our veterans and our service members to come home from war or from serving and say, excuse me, I need some help with PTSD, or I need some help with anxiety, when we as a culture don't do that. And so I was sharing with Ross one of the things that we're working on, and many of you in this room actually are partners in the Campaign to Change Direction, which we launched a year ago with the First Lady. The goal of that really is to change the culture of mental health in America. And if we don't do that, we can't expect to reduce the number of suicides in veterans or anything else. And so that work really grew out of this recognition that mental health is something, as we've all been hearing all day, it affects all of us. It affects all of our families. There isn't anyone who doesn't experience emotional suffering. And we found that for our veterans and military families, that if we move away from the diagnosing and we talk about emotional pain and suffering, which we all experience, it normalizes it, and we're much better able to step up and say, I need some help, I'm hurting. And people around us can recognize that we're hurting.
Right here.
Eric Scharf for the Depression and Bipolar Support Alliance. We've worked with you all to help train peer support specialists at the VA. I was curious if you could talk a little bit more about how peer support and that model can help in the larger system and where you see it going.
Thank you for asking that. Peer support is such an essential new thing that we've really been working on at VA. We continue to hire thousands of peer support specialists who are located at VAs around the country, so that veterans can work with their peers. Many times veterans say, I really don't want to talk with many other people besides my brothers and sisters with whom I served. And so we've really established at VA, the peer support specialists has also had a lived experience with mental illness so that they can really walk that veteran through the process of getting better, showing that there is possibility to get better. But overall, peer support is becoming more and more of a really important type of intervention that we need to continue to use, and we will, so thank you.
Scott Gordon, a couple of years ago, Congress passed legislation permitting access to providers outside the VA system. I was wondering how, if at all, that's affected your work and how it's affected your data gathering.
You're asking me? Oh, okay, great.
Well, for us, I mean, we were actually providing free services before that happened. So for our work, it has just sort of reinforced the importance of the community-based provider. So now what it allowed us to do is, soon after that, we formed a partnership with the VA to help train our providers. We were already doing that, but we need to join together, which we are now doing, to train community-based providers all over the country, because the cultural sensitivity is critical for all different groups. People need to make sure, as they're treating and supporting, that you understand or you ask the questions. So that's how it's affected us directly.
Yeah, and as far as VA, so at every VA medical center around the country, we have suicide prevention coordinators who are the point person for their local communities related to suicide prevention efforts. So being able to really connect those suicide prevention coordinators with community providers for education, for follow-up for our veterans, because as was said earlier, we talk about that 22 veterans a day who die by suicide. It's a very complicated number, but we're using it now. 17 of those who have never touched VA care. So whether they're using care in the community, whether they're not getting care at all, we know that we need to engage with them, because we also know that veterans who use services at VA have lower rates of suicide than veterans who don't use services. So we have just a system in place where we're trying to connect with those. As far as data gathering goes, data is always very complicated, but we are certainly working to get the best data possible.
All right. Thank you.
Wait, I don't want to go. There's too much more to talk about. I know.
All these great questions, too.
Thank you, everybody.
Thank you.